Good afternoon, everyone, and welcome to the Baldrige Foundation's Institute for Performance Excellence webinar, Burnout, clarifying the cultural impact of staffing distrust, low tolerances for stress and change, the high contract labor percentage, and the reality of PTSD. As a reminder, due to the high number of participants, everyone will be kept on mute during the presentation. If you have questions, please submit them to the moderator in the Q&A box located on your control screen. Presenters will answer questions during our panel discussion. Before we get started today, I would like to take a moment and thank and recognize all of our great sponsors, and special thanks to the members of the Mac Baldrige Society who serve as trustees to the Foundation's Institute for Performance Excellence, and our newest Mac Baldrige Society member, About Healthcare. Here is today's agenda and featured guests. Our guest presenters today are Drs. Roger Spoolman and Dr. Chuck Peck, the Baldrige Foundation Leader Dialogue Program co-hosts. Our moderator today is Ben Sawyer with About Healthcare. And now, ladies and gentlemen, it is a privilege to turn our presentation over to our first guest panelist, Dr. Roger Spoolman. Roger?
Thank you, Al, and thank you all for joining today, for taking a few minutes. And I'd also like to say, too, that we have such great admiration for those of you who are in the trenches and dealing with these issues every day. It's to say that we have headwinds and challenges is that doesn't quite cover it, does it? It's extraordinarily difficult for those of you who are working in this field every day and struggling with some things that we want to talk about. And it's our goal, of course, today to not just admire this problem and to talk about it and reinforce it, because I think we read articles and we have a lot of conversations about it, but we really want to provide you with some help and some support in terms of how do we deal with it. So as Al said, if you have specific questions, please use the dialogue box and ask us those questions. We'd love to address those. We have some thoughts for you, but let's first of all frame this situation. All health systems are definitely, if we could go just back one slide, please. All health systems are really struggling with this. And I don't think that we really had everything under control as health systems, even before the pandemic. Healthcare is such a challenging business. It's so important and it's so reliant on all of the skilled healthcare workers that we have, the healthcare providers, physicians, nurses, technologists, aides, everything. And I think that it started to feel the strain even before the pandemic because, well, for a variety of reasons, which we'll get into, but the disruption in this workforce has been amazing. So just a little fact, approximately 1 in 5 healthcare workers have left their jobs since the pandemic started. And why is that? We've got a lot of, the Department of Labor Statistics has talked about 500,000 healthcare workers leaving last May and June. And 63% have said that these are physicians. 63% of physicians have said that they have suffered inappropriate bouts of anger, frustration. People have said that they're suffering burnout for a variety of reasons. So now let's go to the next slide and we'll talk about why. Nurse staffing definitely is in a crisis. I think this is a low number. 22% of nurses may leave their position this year. And again, insufficient staffing has reared its ugly head as probably the defining factor that's created this turmoil. And the emotional toil that is that people are suffering. Maybe some of you have heard about the nurse. She wrote a book about healthcare burnout and trauma in healthcare, Cassie Alexander, that's a pseudonym, but she has recently published a book that talks about the extraordinary difficulties facing providers in healthcare. So what are the contributing factors? Obviously, the uptick in COVID, the rise in admissions due to one variant or the other. There has been a bolus of care that has backed up as a result of COVID and the pandemic. And we're telling people, unless you're really, really, really sick, stay away. And we were telling people for a long time, seemed like a long period of time, if your loved one is ill, don't come visit. So delayed care, people are avoiding admissions, and now they're either seeking access because they can't put it off any longer, or they're avoiding access. And so both problems are not really good. The chronic conditions are worsening. Patients are sicker. They do require longer recovery periods. There's more care that's required for these patients and different modalities. So all points of the system are straining. We go to post-acute care, that's straining. Long-term care is straining. And so no one's safe in this. Now, the retirement impact of this, we've got many nurses, experienced nurses, who have taken retirement packages during the first part of the COVID experience. And so that's doubly difficult because our most experienced nurses were arguably some of the most efficient, and that puts a strain on the newer nurses who don't have the benefit of learning from these experienced people who've been in healthcare for many years. And then changing loyalties. Many of my colleagues, my former colleagues, are talking about contract nurses and what's going on there. They have the same staff, but they're now not working for them directly. They're working for them through a nurse staffing agency. They were paying maybe $50, $45, $50 an hour, and now $200, $225, $250 an hour for the same nurse working the same location. And that hasn't created a lot of goodwill among the staff. It just adds additional tension and very, very disruptive. So there's this crisis of loyalty that's coming. So as I said, we're not trying to just talk about disruptions only, but we want to talk about some solutions. And so I want to ask Dr. Chuck Peck, who is a great consultant, and he has spent a lot of time in a lot of health systems around the country, and he's got some great insights. So Chuck, why don't you share with us some of these contributing factors and what we want to do about them?
Sure, thanks, Roger. So we put up a slide based off of some McKinsey research and a nursing survey that they did this year. And it really just supports what Roger just went through. And that is the staffing levels, the demanding nature and intensity of their workloads, the emotional toll of their jobs, and not feeling listened to or supported at work are really the top four issues that most of them report. And, in the spirit of that, and we'll talk more in detail in a little bit, we're really, Roger and I and Ben and Al, I think, are talking about the idea of building resilience. And I know that, resilience has been sort of used as a buzzword recently, but it really is an important concept to use to try to help people better handle the stress that they're feeling when it arises. We're not trying to be Pollyannish, though. We know that some of the skills that we're going to discuss are not going to be the total cure for burnout, nor are they going to be the vaccine, so to speak. But, there are some things that some of my clients are doing that I thought I would just share some examples of right now, and we can talk more about some specific areas in resilience a little bit later on. If you look at the workforce disruptions or the contributing factors, we're again looking at organizational resilience depletion, the narrowing of resources in the early phases of COVID, which accelerated during COVID, combined with severe staffing shortages in subsequent waves, which have depleted most organizations, probably some of yours as well, pretty significantly. And quite honestly, there have been some leadership miscues, some of which have been inadvertent, some of which are just based on, well, we've always done it that way, sorts of notions. One is underestimating the speed at which the change has been occurring, or even that the change has changed and it's changing under our feet every week, every day. Not really having a good understanding why people are leaving. We're trying to bring some clarity to that today by focusing on just those few things and why they're so demoralized. And I'll give you an example of that here in a second. We're thinking that savings outweighs investments in people. We know that for many organizations, the cost curve has crossed the revenue curve. And obviously, for most of you who are nonprofits, you know that no money means no mission. So there's an intense focus on cutting expenses. And sometimes that means some of our most expensive costs, which are our people. But in the end, that leads to more trouble. There's a bias towards directive communication versus collaborative communication. And there's still an incredibly heavy reliance on trying to solve all these problems with full-time on-site FTEs. And we'll talk a little bit about some of the things that are available to help with that as well. And then there's something we're going to call cultural realignment impediments. We've got to value people as our top priority, and we have to let them know that. We have to relook at the trusting relationships that either exist or don't exist between our people or within our organization right now. We have to be empathetic listeners. We have to make sure they have the true shared vision of where we are now, where we've been, and where we're going. And we assume people may have that already. You know, we have things in frames up around the organization. That doesn't necessarily translate to them understanding where we're trying to go in this particular environment. And then again, leveraging technology in support of some of these things. So let me, before we go on to the next slide and I turn it back over, let me just mention a couple of practical things that some clients have done that have made a difference. Again, they're not the total cure, but they've made a difference. The first thing is, and I know many of you on this call will have a hard time believing this, there are many, many employees, nurses, clinicians who tell us that leadership has still not acknowledged the pain that they're in. And while that's probably basic to you and what you do, this is really an important thing to do as the first starting point. One of our clients developed an online stress assessment. And at the end of that assessment, the employee was able to click and obtain help if they wanted it, either through a telepsych consult or an in-person meeting with somebody. Just giving the ability of the employee to put their thoughts down on what's stressing them and find some help made a big difference. Another one is there's a lot of new nurses and other staff coming on board because of the retention issues. You know, doing some preemptive teaching on how to deal with what this is, which is really PTSD, but having a program to deal with it proactively rather than waiting for some of our newest employees to, you know, be brought down by it is something to think about. And then the last two quickly are, you know, one of our clients had regular visits done by different mental health professionals to the units in their hospital, in their outpatient areas that seem to be suffering the most. Just having those people walk around, talk to people on the units, try to identify folks who seem to be particularly challenged or stressed, and then try to intervene just by being there. And then finally, the last example is offering free therapy sessions, not having to put people through, you know, going through their insurance, worrying about all of the administrative hassles sometimes, but just offering free therapy sessions that people can either take advantage of or not. And again, those are just 5 very practical, sort of down on the ground solutions that some folks that I'm aware of and some organizations have done over the past 12 to 18 months.
Chuck, before we leave this slide, I want to talk about a little bit about the leadership miscues, perhaps. You know, clearly, no one is doing this on purpose. No one is avoiding that. But it seems as though, as I talk to people, the default setting once you get into a crisis situation like we've been in, the default for leadership is to sort of devolve to managing more than leading. And we've got everything coming at us so quickly, and it's just Groundhog's Day every day. You've got the same issues, the same challenges over and over again. And I couldn't help, as we were preparing for this, I couldn't help but think about, we were clients of Gallup for many years, and I know many of the people on this webinar today are very familiar with Gallup. And the Gallup Q12, we kind of joked at the time about these questions because some of them seem a little odd, but they are well researched, and they give real insight into how to measure engagement of employees. And I don't know what's happening with Gallup these days, or these questions, things like, I have a best friend at work. With a lot of people working remotely, if they're not in clinical areas, it's really hard to have a best friend at work, or that the dynamics have switched. And so that's created an additional problem, but maybe we need to find ways to find best friends virtually. Someone gives me feedback about my performance every day. When you're not working with each other, or when there's such crisis and you're putting fires out constantly, working on staffing and that sort of thing, we miss those hallway conversations and in the break room, and opportunities to talk about how's it going and what can I do to help you. One of the questions, of course, is my leader cares about my future. And again, we've missed opportunities because people are resigning, they're leaving, they're joining nurse staffing agencies, physicians. I don't want to leave out physicians. Physicians are people too, and right, Chuck? And so, and that's some of this worries me a great deal, that we're not paying attention to these same types of issues for physicians, and they're feeling left out. I have the tools and the equipment to do my best work every day. That's been a challenge. So, these questions, remember, when people quit, Gallup has told us, they don't quit their job, they quit their boss. Or they don't quit the company, they quit their boss. And so these are things that no one's doing this on purpose, but they perhaps have forgotten how critically important this is. And leadership is still extraordinarily necessary, and we need to do it better in order to address some of these problems. So thanks for bringing these up. Thanks for sharing these.
Sure thing. Thank you.
Ben, you're our resident black belt and Baldrige expert, and the Baldrige Foundation really has done an awful lot of work in this. And as you look at this pyramid, it's it's a busy slide. There's a lot of things, but what I love about this is just what I was just talking about. Colleague engagement is the foundation of this pyramid. So talk about this, Ben, and how we can help our listeners deal with some of these problems in a very productive way.
I'm happy to do that, Roger, and thank you. It's interesting when you're in a crisis, the natural instinct is to react, right, to the symptoms that you're experiencing. And I think what both you and Chuck have talked about is you sort of have to go back and start from a position of balance and alignment, right? So we work at the Baldrige Foundation to create this organizational hierarchy of needs as kind of a visual representation of the Baldrige. And the Baldrige has 7 categories. 6 of them are focused on the different aspects of the organization, and the 7th are really all about the results that you can expect as you do that. So for the purpose of just sort of emphasizing that, just like Maslow's hierarchy of needs that individuals have, organizations have a hierarchy of needs. Let me just unpack this quickly. So the first category is the category of leadership. And as you both have talked about, leaders are under stress and strain. They need support as well. And they're needed more than ever to provide a compelling shared vision, encourage persistent learning, and be there to support what's going on at the front line. The second is strategy. So just because we're in the tyranny of the urgent doesn't mean that the important has gone away. We still need our strategic horizon. So how do we prepare for the future? How do we think differently about the challenges that we're having? That includes, of course, the goals and objectives and key initiatives to be able to align our people with purpose to achieve exceptional results. Customers are at the center of it, right? So the notion of voice of the customer, as you talked about, Roger, people are staying away. Why are they staying away? What are their needs? How can we get that information so that we can adapt and learn within this rapid cycle of change to be able to meet patients and families where they're at, right? Measurement analysis and knowledge management, again, easy to move away from, but the data is there and it's telling us stuff. So are we gaining the insights, right? Do we secure and use reliable data and information to make effective organizational decisions? Or because of the tyranny of the urgent, are we tending to make reactive responses? Workforce, as you said, colleague engagement is at the foundation of the pillar. So being able to engage all members of the workforce to ensure that roles and responsibilities are clear, they're supported, they're empowered in the discharge of their duties to the benefit, right, of the patient, the consumer, and the organization. And then that all comes together in operations, right? So there's process inefficiencies, there's technology support, support of operations. So how do you design, manage, improve, and innovate, and continue to innovate your healthcare services and work processes to improve operational effectiveness and deliver value? And I think what the challenge is how do you turn all this disruption and change into opportunity, right? We had done a series on that, if you recall, in the first wave of COVID, and it was very insightful. I think we had about 500 executives participate in that. But that question remains. This is probably one of the most disruptive, if not the most disruptive, time in healthcare. So how do we turn disruption and change into opportunity?
Great question, and I'm sure our audience is interested in that, Ben. As if you're running a health system or a department or division, and you've got no ICU beds, they're completely full with COVID patients, or you don't have enough staffing and people are backed up in the emergency department. 57% of your physicians said that they've experienced tearfulness, anger, frustration, anxiety. You got 61 who are burned out. The first thing that comes to mind is not, what we need? We need to start a Baldrige journey. And that's not the thing that comes to mind. That's for before the crisis or when things are stable. But this hierarchy of needs is so helpful. And I think if we could take a little bit of a time out in the midst of that crisis and focus on a few of these things, which you've identified, which is really helpful, Ben. Thank you.
Yeah, sounds good. Al, I think your audio is on, so I just wanted to give you a heads up on that. All right, so Chuck, back to you. You had started to talk about these practical considerations before, and I was really intrigued with that. Are there others on this list that are particularly meaningful?
Yes, Ben. So let me just, if I could, just let me take 1 minute, literally back up to what we were just talking about, because I think there's one other important point to make here. I don't want to diminish one iota the stress, the strain, the fatigue that all of the leaders that are probably on this call are also feeling. And so this is not just about staff, physicians, it's about leadership as well. And so I'll use a crazy analogy here for a second, but if you're preparing for the Super Bowl, you've got 60 minutes for the biggest game of your life. You want to make sure that you are in the best physical and mental health that you can possibly be in, because you're going to help lead your team to victory or not. And I just want to point out how important, I'm a physician by training. I know that I wasn't very much help to patients if I myself wasn't feeling well. And so thinking about a couple of things, are you taking care of yourself? I know we all feel like we're responsible for the thousands of people that work for us, but we're also responsible for making sure we take care of ourselves, Because if we don't do that, we're not going to be able to lead effectively. In other words, asking yourselves, are we mentally and physically fit right now to lead in this incredible time? And if not, what can we do to help ourselves be healthier that way? And, are we specifically focused on doing any kind of special training for this game that we're in? So are we trying to learn some of the techniques and, going out and reading about some of the things we're talking about today to try to address some of the issues that we're having to face 24/7, 365. So if you go to the next slide, Ben, I'm not going to go through this list. I'll let you all read it. There are a couple of things I just wanted to touch on that I think are really, really critical on this list. First of all, I think we talked a little bit about this, but focusing on peer-to-peer support programs is a really, really important thing to focus on in trying to get through the issues that people are facing. I also want to point out to something I mentioned earlier, which is on the bottom of the organizational investment list, and Ben's going to address this in a second, and that's to try to fully leverage all the technology that we currently have. We've spent millions and millions and millions of dollars on technology, and most of my clients are maybe using 30% or 40% of what they've invested in. And there are some tools that we'll talk about in a few minutes that can also assist with some of the things that we've been talking about as well. This isn't about full-time FTEs all the time as the only thing that's going to work. And then the last thing, and I just want to spend a minute on this, is going back to this idea of building resilience. And, some specific questions that you might, want to ask yourself and then potentially answer. What is making my staff so unhealthy feeling? Why does our work environment lack the conditions for them to flourish? How can I make it safe for them to work here every day? And, we have to really dig into data, not make assumptions, and ask our people, just flat out ask them, what would make work better for them? People really react negatively, especially under stress, to what I'll call feeling pebbles in their shoes every day when they're walking around, right? So what's a pebble? A pebble can be something as innocuous as, we took the coffee away in the break rooms. We don't have coffee anymore. A pebble can be, every time I try to print orders off, this printer, I've been talking, and this is a real story. This printer, I've been talking about it for months and months and weeks. It doesn't work. Every time I want to print something off, I have to go to another unit to get it printed off. That's a pebble. And those pebbles really, really build up, especially at times like this. So we just need to start asking people what they need. And, one way to ask the question would be something like, if we had this much budget and could spend it on X, many items or things in our department, what would the first priority be? That's a very non-threatening sort of a question to ask folks. And, your employees may not have the perfect, silver bullet solution, but they certainly can tell us what is working, and they could tell us what isn't working. And many of the times that's the most invaluable data that we're going to get. It's understanding from our employees directly. They know that everybody's under financial strain. And there's probably not enough money in the world that you can give them in terms of bonuses and everything else to keep them from looking for places where the grass is greener. But there are probably some inexpensive, simple things that we all can do to make their lives easier and to make them feel like they're part of the family, and then are willing to sort of stick it out with us, either because of loyalty or because they got into this in the first place to take care of folks in their own communities. Ben, I'll turn it back over to you.
Great.
So Roger, you and I were talking about this. We had Dan Beckham on the last podcast, and he wrote the monogram "Healthcare on Fire." And you had pointed out that some of the things that done to support staff used to be nice to haves, and now they're kind of must haves. That I was reminded of that when Chuck was talking. Did you want to elaborate just a little bit on that before I get into some of these technological support opportunities?
Well, probably the one that comes to mind, Ben, more than anything else, is leadership development. And, we have hospitals have so many leaders, whether it's a unit, division, department, the system, whatever. We have leaders and managers all through our systems, and things go better when we support them with practical information, practical knowledge, and teach them how to be better leaders. And as I said earlier, in a crisis or in constraint, when there are constrained resources, and that could be time, staffing, money, anything, in those times, the default setting is to managing and not leading. And so you've got a bad situation. We make it worse when all we're doing is, I'm just trying to fill these boxes, these shifts. I'm just trying to staff, instead of investing in our people and helping them get the joy out of not only their own work, but the work that they can do to support others. So it's a must-have. It really is. We used to do that all the time. So many people invested in it, but right now I'm afraid that has gone by the wayside. Why? It's too difficult. We're so many of our leaders in a remote environment, when we were social distancing, and when we're, all of these factors are making it so difficult to do healthcare the right way, the best way possible. We're still doing it. We're still providing quality care in an appropriate setting. But, these other things that really set us apart and really added to the whole transactional, relational healing process, I'm afraid it's missing.
Yeah. Well, it was interesting in that conversation you recall with Dan, and for those that haven't listened to that podcast, it's available on the Leader Dialogue site, but he talks about how change has changed.
Yeah.
Right. And the metaphor always used to be the frog in hot water that, was in the pan and eventually they got cooked. He said now the metaphor is really more like putting a frog in the microwave, right? You have no chance to really respond. So it has to be a very conscious effort. So in that regard, let me just talk a little bit with everyone about the kind of technological considerations that you may want to make in terms of addressing these disruptions. So obviously staffing is in flux. We've clarified that, and people are stressed by poor operational systems and processes and need automation support. So we've known for years as a lean black belt, it's well proven and understood that about 40% of process is waste. It's non-contributory towards the consumer benefit. It stresses the staff. That just becomes more exacerbated in these kind of environments. So to give you some practical examples of what to look at, let's just talk about the inpatient setting. So to confront the disconnects, first of all, on the front end of the hospital, getting patients in can be very difficult. It could take 3, 5, 7 hours sometimes because everything is so manual. You don't have on-call providers scheduled. You don't have computer-aided dispatch for transportation and so forth. So there's manual processes, there's fragmented reporting, and the impact can be, you're not doing well with accommodating patients and you get patient leakage. So a way to address that from a technology standpoint is to create a hub where you can have seamless access with processes and technology, and you integrate those functions, right? The on-call provider coordination and computer-aided dispatch for all of your EMS transport. Another is highly variable discharge planning, right? Particularly if it's happening at the end of the patient's stay. Everybody knows that adds excess days, which further compromises capacity when you have high demand. So being able to, have just reliance on staff to determine estimated date of discharge and what, the patient disposition information can kind of perpetuate these patient care progression delays. So what if discharge instead is initiated on admission and you're using estimated date of discharge and disposition intelligence using your technology to drive multidisciplinary, that's the MDR, planning and action. Another is it can be very tedious to manage and resolve barriers. You didn't even know they were happening. You know, the MRI is being used by an outpatient, or PT's up on the unit ambulating the patient when radiology really needs to get them. These things stress workforce. So it's just too many open orders to track. They have to text and call to try to figure out what's going on and prioritize it. So what about using artificial intelligence and machine learning opportunities to identify rate limiting steps and prompt next best steps, and essentially reduce that scurrying around trying to figure out how to get the patient best through that care process? The last one is on the post-acute process, right? There's a lot of access and transport impediments. There's chaos at the end of the stay, and that overloads the care team and resources. So what if instead you were able to look at a whole curated network of providers that are clear and available, and you're working again on those right at the beginning of stay and determining where that patient needs to go, finding effective tools to manage those pack reservations and transport. Those are just some examples of how technology can help. And what it's basically doing is taking the stress and the compromising of results that occur and working very intentionally to decompress the staff and drive sustainable results. And often what happens with the EMRs is they're great. I mean, you have to have them for your clinical documentation and processes and so forth. What you're looking for are things that augment that, right? It kind of what I would call composable solutions to effectively address some of these performance gaps and maximize the measurable results.
Great example. There are some other things too that we can look at and we want to get to that portion of this webinar today and address any questions that our audience has. We do have some questions that have come in early that we can probably begin to address to get the ball rolling.
Yeah, I'm getting that feed, Roger. So let me start off with a few of these that came in. And I'll just address this to both you and Chuck. What practical and proactive steps can systems take to address and prevent provider burnout?
Boy, if I could just start with that and just say how difficult that is right now. I still live in a community where I was the CEO of the health system, and I run into some physicians now and again in the store. I ran into a physician friend of mine in the grocery store the other day, and she was actually doing really well. Why is it? She's a primary care provider, works in the large physician practice. She was doing really well because she'd been off for the last 2 weeks. She had fallen and pretty severely broken 2 fingers that required a really extensive fracture repair. And so she was on medical leave. And she just started sharing with me some of the frustrations that she's had and her colleagues. And, she was doing fine, but she said that medical leave came at a time that was just so critical to helping her keep her sanity. And we got into a conversation about what was going on and what caused the frustration for her prior to this injury that she had. And it came right back to the EMR. Her days were long. They're extended because of documentation requirements. And in the midst of COVID, and we've got additional documentation requirements, not less, more, not less. And she started talking about her colleagues who are leaving, not leaving medicine, but leaving to start a concierge practice or some of the other options like that allow them to do some more remote medicine or have time on their own. And she frankly said that the only reason that she'd been offered the opportunity to do that, but one of the chief reasons she hasn't done that is because of her loyalty to her staff. My staff need their jobs and they need their benefits. So that's kind of a sad commentary, isn't it? We've got providers who really want to leave. And I said, what's one thing that really could make things different for you, better? And she said, I just wish administrators, including physician administrators, I wish they would just listen to us. Listen to us. That's not very difficult, but just listen to us. And so she obviously she felt like she wasn't being heard. So anyway, long preamble, but Chuck, go ahead. What do you think? What are your experiences?
Yeah, so the number one thing that I was going to mention was again, what I said earlier, which is just go and ask questions and listen. I think that's, when I was a CEO, I did the same thing. I made assumptions. I thought I knew what people wanted. I was wrong at least half the time. And I wouldn't presume to know what the answers are going to be in your particular systems. But again, I know of one place where asking the question that I mentioned earlier about how much budget could, and if we had X, what would you spend it on? And what would be the first priority? And, one of the biggest issues, you mentioned this too, around the EMR, is get me a scribe.
Yes.
Okay.
Yeah.
Or number two, I'm a surgeon. I've been talking about the inefficiencies of the operating room. I don't want more money, but what I would really like is if I have 4 cases scheduled, I'd like to be able to do those 4 cases. I don't need to have the OR shut down. I don't need to have other patients pushed into that spot. I don't want you to pay anymore. I just want to be able to be more productive. And, again, if we just ask people, walk around, manage by walking around, ask people what it is that we could help them with that doesn't involve just writing them a big check. I think you'll find that very few ask for the big check. And a lot of what you're going to hear are things that you probably heard 5, 6, 7 years ago that never got implemented or executed upon, that could be done at low cost to everybody, but cause, a bump up in satisfaction. And I think feeling burned out by not being heard is probably one of the things that we hear the most. And it doesn't matter what level in the organization you're at. If you're at the lowest level or the highest level, that's probably one of the biggest responses is nobody is listening. Nobody's acknowledging what I've been saying for a long time.
Inc. magazine recently had an article about the Great Resignation, and this isn't just healthcare, of course. This is all across all sectors, and why millions of people now employers, are leaving, and how employers can earn them back. And I thought that was a really interesting subtitle: how employers can earn them back. We can't attract them back with bonuses and we think we're doing a good thing by offering our own employees recruitment bonuses. Talk your friends into coming to work for us, and we're going to pay you if you do that. Well, then if your friend comes and finds that this is a very dysfunctional workplace and there's lots of pain and problems, that's going to put a strain on our relationship, right? So nobody wants to do that. And so they even quote, I don't consider Mark Cuban, he's an interesting character, but, they quote Mark Cuban in the article, and he talks about employees treating people badly. He says that is unforgivable. And when we are in the midst of a crisis, and I'm talking to us as leaders, when in the midst of a crisis, we have all these things, it's easy to say, nobody understands the pressure that I'm under. Nobody really appreciates all that I have to do. And so we make it about us instead of making it about the people that we're there to serve. And we forgive our behavior, our unforgivable behavior of treating people badly. And what you're talking about, Ben, what you've talked about, these things don't cost any money. It's just the cost of attention, our attention and focus. And that is our primary job.
Yeah.
And we need to make time in our schedule to do exactly what you've said, Chuck. Ask questions.
So this next question couldn't have been more timely based on what you guys just talked about. The question came in, how can we better listen to staff and engage them as partners?
Ah, great question. Yeah. I think that we forget that when people come to work, they don't leave their problems, they don't leave their home situation, the stresses that they're under away from work. Those don't stay in the car, in the parking lot. They bring them in. So I bring my whole self to work. And being attentive to that, I think, is one way that we can really demonstrate that we really care about people. And Chuck, you've said it a couple of times in this webinar. What can we do for you? Is there anything we can help you with? And you're right, we're already paying, it seems, in most health systems, you're paying above average wages. And at least, that part, those hygiene factors are cared for. But what is it that we can do to distinguish ourselves as an employer? We can care for people not just by our words, not by our slogans, but we can truly care for them by talking to them, making it part of the culture. We care for each other.
Right.
What can we do to help each other?
That's great insight. Chuck, to follow up on that question, how can we better listen to staff and engage them as partners? What does that evoke in terms of response as that question is posed, the partnership concept?
Yeah, so in my experience, at least, the best way to engage people is to have them feel ownership for trying to help solve the problem. Okay. I can't tell you how many organizations I'm in every week that are incredibly top down, where when you get below the leadership team or the director level, a lot of the employees feel like they're order takers, right? And again, the reason to ask the questions is that, and again, I found this in spades when I was a CEO. The frontline staff have the answers to a lot of our issues, but we're not asking them, or they don't feel empowered to speak up and give us some of the answers that we're looking for. And we somehow assume that the title of leader means that we must know all the answers because we know how everything is interrelated and we know the budgets but it's amazing by just walking around doing department meetings. I'm in a place right now where the leadership team is just really, really, really dysfunctional, and they're in what I'd call the blame game, the valley of despair. And I met with them about a week or so ago, and I said, I know you guys are just buried with everything. You're busting at the seams with COVID. It's would you guys be interested in any leadership education? Would you guys be interested in some investment in your being, as opposed to just spending all day long in the whirlwind, going from one crisis to another? And I thought they were all going to just blow me off. We don't have time for this. This is crazy. How can you even bring that up at this point? We're shutting down. And to a person, they looked like, oh my God, nobody ever asked me that question before. And it would sure help me if I had a few tips on what I can do about these crises that I'm dealing with every day. And how do I learn how to focus on what's really important and what my mission is? Because I get up and come to work every day, really mostly because I really believe in what I'm doing for patients, for my community, for my family, etc. And if somebody would just give me a little breathing room and some time to think about that, feel good about that, learn how to maybe use some of those positive influences in what I'm doing day to day, it would be huge. So get it all the way down, again, to the lowest level in the organization, and get them to own it and be responsible and accountable for it, and they will engage. I've never seen that not work.
That's a great answer, Chuck. And it seems like some of the simplest things are the most profound, and they have the most profound impact and effect. I mean, it's even if it's just, here's an article, let's read this article together and discuss it. Or it can be so simple. We're going to do on our Leader Dialogue webinar, or excuse me, our podcast, we're going to talk about how to lead when you're not in charge. And I think that that's going to be a very interesting discussion of how to help people have their voice heard. And it's not just complaining, it's really adding to the solution, becoming part of the solution, not just adding to the problem. So,
Yeah, everybody on this call, whether they consider themselves to be a leader or a manager, everybody has influence or can have influence.
Yeah.
And learning about influence and forgetting about titles and hierarchies, I think that would be really beneficial for a lot of folks these days.
Yeah, absolutely.
So you guys, we have time, I think, for a couple more questions. There's a question that just came in. It's kind of an observation. We're seeing the same trends in public health. Many public health staff, including directors and nurses, are leaving due to burnout or better offers from hospitals and clinics. So this isn't obviously isolated to hospitals. And this actually ties to another question that came in. How do, in fact, our work environments prevent staff from flourishing, and how could we change that?
One of the things that we haven't really talked about enough, I think, is, we're talking about burnout of the providers and both nurses, physicians, clinic staff, all of that. And, we all have said this for years, the patient is at the center of our care. And I don't hear as much talk about, we are saving lives. When patients come in, they're in such dire straits, they really, really, really need the services that they're being given in the emergency department, in the ICU. But it's the patients and their family members. And our healthcare workers went, as we know, from hero to zero in a very short period of time.
Mm-hmm.
And, I don't know that they've been acknowledged enough. Chuck, you just mentioned this a little bit ago. I don't know if we've acknowledged enough the real true cost, the PTSD, the true cost of seeing people dying and dying alone or very, very ill. And the patient's family often was the best source of information on how to treat the patient in the past. And now we don't have time to talk to them. And so it's no wonder that patience is wearing thin, that people are getting frustrated. They're leaving the field if they have opportunities to go elsewhere. We need to start regenerating and to creating our own talent pool to get people in love with healthcare again. And so I think for me, it's leaders. It's the job of the leaders to be attentive to these things and to see them before they become a crisis. And put your own mask on first, leaders. You got to, as we've said, you got to take care of yourself first.
Yeah, I don't know who asked this question, but I think it's really, really insightful. Because, I think we've all tended to think of burnout as an individual problem, right? Just say no when somebody asks you to do something, do more yoga, practice resilience. Of course, we don't tell them what that means, et cetera. There's a huge list of things that everybody's telling individuals to do. But when you look at the data and you look at the, official sort of definition of burnout, it becomes obvious that the responsibility for managing it really has shifted away from focusing on the individual and more towards the organization. So it's everybody on this call's job to build a burnout strategy. And, some of the things that we've talked about today, some of the practical things, some of the ideas we've given you are meant to do that, because, you wouldn't be on this call if you didn't feel that it was part of your responsibility. And I think that's a start.
Well said.
So Roger, I don't see any other questions coming through. I think we're about 5 minutes to the hour. So if on the webinar, if there are any other questions, we can accommodate those. Otherwise, Roger, I'll turn it back over to you for kind of a summation.
Okay, thanks, Ben. One of the things before we start that I didn't know where this might fit, but today's Wall Street Journal has an interesting article talking about the healthcare systems across the country are who's sort of walking back their vaccine mandates. And it's not our intent to get into the political discussion about vaccines and that sort of thing. But I thought it was very interesting. And if you haven't seen it, it's worth a read. And of course, the rationale is there are many people who have applied for exemptions, whether it's a religious or a health related exemption from the vaccine. They've been ostracized. They've been so it's been so difficult that they've quit. So we've sort of created this, we've made it worse. We've made the shortage worse. And now many healthcare systems are saying we will no longer require our employees to be vaccinated. They're going to add testing. There'll be opportunities for regular testing for people, which is good. We're going to keep people safe. But their hope, I think these systems, their hope is that they're going to bring back some people. And I'm not sure that they're going to, but we'll see. Maybe that's a topic for discussion on the podcast. But we are so grateful that you've tuned in. And as we've said, we want to be a source of help to you and a source of encouragement to you. And we hope that that's what's occurred. This is just the beginning of this discussion. We want to have several more and provide people and thoughts and resources that will help you deal with this tremendous crisis. Again, thank you so much for all that you do to lead in this very difficult time, and for those who are sacrificing perhaps their own health, their own mental health. We haven't even talked about mental health, and that's a huge issue, but perhaps we'll be able to do that in the future. So thanks for being with us today, and I'm going to turn it back over to you, Al, for some closing comments.
Thanks, everybody, for tuning in today. We appreciate your participation and your active engagement, and thanks especially to you, Roger, Chuck, and Ben, for such a thought-provoking presentation. As a reminder, the webinar and the additional PowerPoint slides will be on our website within 72 hours for you to be able to view and download, and continue to watch for additional webinars from the Baldrige Foundation Institute for Performance Excellence. And thanks to all of our sponsors, and especially the Mac Baldrige Institute trustees and our newest trustee, About Healthcare. Have a great day, everyone.